Good afternoon, dear colleagues. Thank you for the opportunity to participate in the debates and the discussion as to stenting of the carotid artery in a symptomatic critical stenosis. My presentation is not a lecture or some deductive content. It's a discussion, and according to the scenario of our conference, I should say that I'm for stenting in a critical symptomatic stenosis of the carotid artery. Having heard the previous presenters, I understand that we have the opportunity from the different trials, clinical trials, to, so to say, extract the information we like. All the same, we are trying to be objective while analyzing the previous trials, and even those trials that are in favor of surgery. It's a cactus studies showing very good results, but I understand that these results can't be acceptable because the design was a bit different. If we analyze A3S and SAS clinical trials, it's a way we worked when in the UK ICA's studies they used only 70% of cases. Experience of a surgeon was not very extensive. There might be very long discussion. Turning back to my presentation. I'm for, but if the level of early post-operative 30-day complications, stroke and death less than 6%. Also, from previous presentations, you know the recommendations of the European Society, the American consensus recommendations on stenting in symptomatic stenosis. I'm not going to dwell upon this. Once again, I'm for if the catheter laboratory comply with the indications. What is high qualification for the stenting? For GPP, it's not less than 150 cerebral angiographies in 2 years and 75 carotid stenting in 2 years, out of which 50% were made personally. If we look at crest on this pie diagram, it's clear that doctors who could do stenting, 42 interventional cardiologists, then vascular surgeons, then interventional radiologists, and so on. Having analyzed the complications, it was found out that the less had interventional cardiologist, but it relates not to the technique of the procedure, it relates to the fact that cardiologists they do catheterization daily, not less than 16, 18 catheter application. If we look at the CREST studies, the primary endpoints including stroke, infarction and death in the group of patients, stenting patients and surgery, they were similar. Well, the question, why we are talking about infection of myocardial infection? It's a very important question. After this sub-study, CREST sub-study, it was proved that 4-year survival rate of patients with infarction in surgery was less than in patients who suffered from low ischemic infarction or stroke, sorry. If we look at the number of the patients in these studies, main patients, they were enrolled after 2006. And if we analyze these subgroups, it's clear that since 2006, since the time when more than half stenting was performed, we can see considerable lowering of death in angioplastics and stenting. Since 2006, the mortality rate is decreasing in angioplastic, carotid angioplastic, and even since 2006, symptomatic patient death is decreasing. Patients older than 80 years, since 2006, 0% of death and large stroke, major stroke. It says about the fact that doctors have become experienced, and due to the increase of volume of endovascular intervention, the quality of these interventions and patient selections are improved as well. What in Russia? These figures currently in the Russian Federation, 17,000 and 18,000 carotid revascularization performed. 16% amounts to endovascular interventions. For 1 million of population, it's 124 operations. In the USA, this percentage is a bit higher. As we heard from our Finnish colleagues, they have less than twofold revascularization of carotid arteries. What should we point out? The overall the number of hospitals in 2012, 201 clinic performed revascularization of carotid arteries, including stenting, angioplastic, and so on, and less than 50 per year, 50 operations out of them. Now we are talking about the quality of our treatment on mortality, basing on mortality rate and stroke in 30 days. Out of all the resources that are available now, I couldn't get the figures reflecting the situation in Russia. Mortality and major stroke in in patient with revascularization. Once again, I am for routine stenting of the carotid artery if intraoperative, if complications are evaluated by independent neurologists and MRI is performed and DWI is performed. And of course control on the volume of numb lesions. As to independent neurological expertise, it's all data. 16,000 patients were analyzed who were performed carotid enterectomy on. The number of perioperative strokes and deaths increased when independent neurologists analyzed the work, and figures quite considerably low if only interventional surgeon analyzed this. Any patient who is for carotid revascularization with stenting is evaluated by independent neurologists before and after the operation, and all the patients they are performed DWI and MRI, so that to evaluate the 30-day level of complications. What happened to patients who discharged patients before these 30 days? Who evaluates this indicator? It's a kind of a comment. I'm for if in the laboratory a doctor knows morphology of the bifurcation plaque, what kind of plaque we have, uh, and anatomy of the aortic arch before the catheterization. I am for routine using angioplastic plus stenting if the laboratory can do proximal and distal protection at a very good level. It's very important for symptomatic patient with the critical stenosis. And of course I am for if I know the level of complications of my colleagues. I don't know their official figures about mortality and stroke rate in the surgeons who worked in different clinical establishments. It's a nonsense. I can't get to these figures. In conclusion, I'd like to say that the choice of the way of revascularization is based by, so to say, carotid team. In this team should include neurologists, vascular surgeons, endovascular surgeons, cardiologists who treat comorbid background of these patients. And briefly, I'd like to repeat about some points that a previous presenter mentioned. Of course, there are anatomic peculiarities. I'd like to say about the first, occlusion or critical impairment of the iliac femoral segment. We can perform, it's not very critical, we can do through the upper limb, upper extremity, and twist or winding of the common carotid artery. In conclusion, I'd like to say a few words regarding independent open analysis of perioperative complications allows us to choose the methods for vascularization, the method that would be suited for this patient, for this laboratory, for this department. The feasibility and the way of revascularization is defined by the team, including neurologists, endovascular surgeon, and vascular surgeon. And if we have anatomic morphological characteristics that will complicate the placement of catheter or stent, we should take this into account.
Thank you for your attention. Thank you for your presentation. Please, questions. Please, use the microphone. Oh, with a great deal of pleasure. Igor, first of all, thank you very much for the interesting presentation, especially for your point of view regarding skill mix. And that's my question. It's well known that there are some indications for CA in symptomatic patients, and the procedure should be done within 2 first weeks of symptoms onset. What's your attitude to the procedure? Why don't we perform stenting? Well, those are the indications for symptomatic patients who underwent, who actually developed transitory ischemic attack, TIA. Yeah, well, this patient is eligible to angioplasty or stenting? Yes, why not? Thank you, Igor, for your interesting presentation. Indeed, again, you emphasize the multidisciplinary approach. Basically, what's going on in our unit, Professor Sorokaumov mentioned the same. We need like an independent angioneurologist who, in fact, evaluate the patient before and after the procedure. How do we do it in our unit? You know, the same angioneurologist follows the patient up like 6 months after the procedure, 12 months after the procedure. Well, your comment regarding the fact that you are not aware of what's going on with, you know, uh, your neighbors. Okay, let's combine efforts. You know, uh, yeah, I believe we have to develop the registry, like for St. Petersburg. Well, why not? To conclude, yeah, I would like to, in fact, approach Professor Sukurenko of Soroka. Maybe indeed we have to start acting. We have to start the development of the registry in order to be able to again do benchmarking to evaluate our performance. And yeah, it doesn't mean we are going to punish colleagues. Sure, I am in charge of my cath lab, but why um, did we make the independent neurologist evaluation involved? Like a surgeon, you know, would be intimidated if he or she would have to admit the defect of the performance, his or her performance. Yeah, that's why we need the independent evaluation. So we tried, in addition to all that, we tried to do research to evaluate like effectiveness of our revascularization versus golden standard. So we decided to do it at the city level. Okay, let's refer our patient to MRI before and after and arterectomy, and let's compare proximal versus distal protection. No matter how strange it sounds, we even were willing to assume financial responsibility for this research. But you know what? No one responded to our plea. On behalf of vascular surgeons, I can tell that it's not just a refusal of vascular surgeons to analyze their performance. Maybe these people, like vascular surgeons, are too busy to do operational research. And so we limited our research to our hospital. Well, I am your ally. I'm willing to provide you with whatever information you need in order to figure out, how well do we treat our patients.
I hope you get along with evaluating all the process, but coming back to the reason why we're doing interventions is the stroke prevention, right? And we know that the faster we do carotid endarterectomies after the index event, the more strokes prevent. We are at our best, we are getting to figures NNT2 with some women. I'm touching a bit upon that, but what I'm lacking in these discussions is the same figures about stenting. So if you go stenting below 2 weeks, within 4 months, or within 4 weeks or so, how do the figures go? Because we know from EVS 3 long-term 10-year results that the stenting prevails. It's a good long-term treatment. But what happens in the first 2 weeks?
Oh, thank you for your question. I must admit, it's a very precise and a very important question. About 1/2 of ischemic events in patients who underwent angioplasty and stenting take place within 2 first weeks, when patient is already discharged from the hospital, like after stenting and endarterectomy. That's why we were interested in comparing this silent ischemic loci. Yeah, we need to know more about this, like a 30-day period. From my point of view, it shows uh, symptomatic versus asymptomatic clinical events. That's why we ask patients to come back within 30 days, and we try to refer them to ultrasound and evaluate them, the patient assessment. But you're right, absolutely right. These first 2 weeks, uh, this immediate, not the immediate results of cath lab, but this first 2 weeks, unfortunately, very eventful in terms of vascular events. I neglected to mention, but now I would like to thank the colleague from Poland who demonstrated like a great clinical outcome. But again, maybe it's like he's a proponent of endovascular surgery, and only vascular surgeons are capable of managing such a dreadful complication. I have a question. Okay, this trend to operate within 2 first weeks after stroke, we know that this, the plaque as a rule is unstable. We see like thrombi on the surface of the plaque. That's a plaque with no cover, no coat. Even in this situation, we believe that and the vascular interventions are superior. It's more cool. It's not for the translation. No, that's an attempt to make to perform coherent tomography. We tried hard to recruit our colleagues from the Military Medical Academy and ask them what did they mean by unstable plaque. What do we need to confirm this diagnosis? Ultrasonography, maybe ulcerations, but it's not a matter of principle for a vascular surgeon. Anatomical difficulties. Any, yeah, uh, complicated catheterization prolongs the procedure, but we have to be perseverant. But at the same time, it increases a risk of thromboembolic events, especially in elderly patients. As for the thrombocephalic arteries, again, instability of the plaque is not like indication or contraindication, even though it's a very interesting subject. Oftentimes, we take referrals from the light laboratories. The patient who underwent end arterectomy, and we even don't know how to interpret our findings. It's a very, very interesting subject. What are the predictors? Like high frequency CRP or what? It's a new area for our research. But as for ischemic events in connotation of protection system, well, again, unstable plaque is not critical. Like a very complicated anatomy is a limitation, for me at least. More questions? No? Thank you, Igor.